Hello, everyone. Welcome to our Translation Neuroimaging Educational Program. I'm the moderator for this event today. My name is Ruiyang Ge, and I work at the Department of Psychiatry at University of British Columbia. Before introducing our guest speaker today, please allow me 2 minutes to have a quick introduction of our educational program. This program is nested within the Lifespan Working Group of the Enigma Consortium, which spans more than 45 countries and involves over 4,000 researchers worldwide. Our program is an inclusive program that welcomes researchers at all levels of neuroimaging skills and from diverse training backgrounds. The directors of this program are Dr. Shalala Haas from Mount Sinai, New York City, and myself, and we do have an international advisory committee. Please consider to join our mailing list if you wish to receive notification of updates about our program. We have a YouTube channel where you can find the recordings from previous event. As you may have noticed, I'm also recording today's event. So if you are interested, keep an eye on our YouTube channel. We will be uploading it very soon. Just a heads up, we are only be sharing the presentation by our guest speaker, not the question and answer part. So please feel free to raise any questions for our guest speakers after their presentation. We are on both Twitter, now it's called X, and Blue Sky. So if you are in either platform, we would love you to follow us there. If you wish to share your work through this platform, please get in touch with us. We welcome any type of collaborations. Today, we are very excited to have Dr. Jianxun Ren. Dr. Ren is a principal investigator at Changping Laboratory at Beijing. Dr. Ren's work centers on 4 primary areas: localizing and analyzing brain functional circuits, personalizing neuromodulation therapies, particularly for conditions like Parkinson's disease and post-stroke impairments, uncovering how neuromodulation actually works, and enhancing neuroimaging techniques using deep learning. He uses a range of cutting-edge tools, including advanced brain imaging, neuromodulation methods like TMS, deep brain stimulation, and focused ultrasound simulation, just to name a few, machine learning, and genomics. Dr. Ren has published over 30 academic papers in high-impact journals such as Nature Methods, Nature Communication, Medical Imaging Analysis, Brain Stimulation, and so on. Today, Dr. Ren will be sharing recent advancement in deep learning for MRI data processing and will introduce his latest work on DeepPrep, which is a novel and very useful tool for fMRI processing, which was published in Nature Methods earlier this year. He will also introduce the clinical applications of DeepPrep in personalized functional circuit-guided neuromodulation. So, Dr. Ren, now the microphone is yours.
Okay, let's begin. Today, I'm glad to share our recent progress in functional neuroimaging and personalized neuromodulation. The core of this work is a highly efficient fMRI pre-processing pipeline we call DeepPrep. DeepPrep now becomes the foundation for many of our clinical studies for personalized functional circuit-guided neuromodulation. I'd like to share 4 topics today, including the development of DeepPrep and also the personalized functional mapping and validation. After this, I will show how DeepPrep and personalized functional mapping facilitate precision neuromodulation for post-stroke functional rehabilitation. Last, I will introduce a novel circuit in Parkinson's disease. This is my favorite study, by the way, so far. Okay, let's begin. The development of DeepPrep was majorly driven by 2 motivations. First, we are entering the era of big neuroimage data. The amount of fMRI data is growing exponentially, but the pipelines we are using today were mostly developed decades ago, like FreeSurfer, FSL, and SPM. They were designed for small simple size, and now they can't keep up. Second, most pipelines are good at processing.
We may lost you. or you're muted. Sorry about that.
Right now?
Yeah. Yeah, so it's good now.
Okay.
Yeah.
Can you see my screen?
Yes.
Okay. Second, most pipelines are good at processing like clean and well-controlled research data, but real-world clinical data is messy. They have lesions, head motion, like missing tissues, and all kinds of variability. Traditional tools often fail or produce unreliable outputs when applied to these challenge cases. So we need a new solution that's not only fast but also robust enough for real clinical applications. Regarding the time efficiency, I'd like to take FRM-Prep as an example. FRM-Prep is one of the most widely used FMI pre-processing pipeline, but it's based on the traditional algorithms. So on average, it takes 6 to 8 hours for each scan and even days for clinical samples. The most time-consuming steps include like volumetric registration, tissue segmentation, surface reconstruction, and the surface registration. This complexity makes it super slow to process the large scale data sets and difficult to apply in clinical settings, where patients can wait for like days just to get data pre-processed. So our goal is simple but ambitious. Build a new pipeline to cut the pre-processing time down from 8 hours to 30 minutes. Here, I'd like to show two examples where deep learning algorithms accelerate the time-consuming steps. First is the cortical surface reconstruction. This is a critical initial step in surface-based analysis. Free surfer takes around 45 minutes for the process. To accelerate the procedure, we would develop a deep learning algorithm called faster CSR. Faster CSR reduces free servers 45 minutes to just 2 minutes. More importantly, faster CSR can handle the tricky scans like this stroke patient that traditional tools struggle with. Here I showed like the two stroke patients that free server failed to reconstruct the surfaces, but faster CSR delivered the high quality results. This makes surface-based analysis more efficient and more inclusive for patients with brain lesions. Second is a cortical surface registration. This is where we align individual brain surfaces to standard templates like FS average or FSLR. Free surface is a standard tool for surface registration, but it often takes over like 30 minutes. So we developed a deep learning model to accelerate the procedure named Sugar. Sugar successfully accelerated the process from over 30 minutes to just 0.2 seconds. It's 200 times faster. But the speed isn't the only advantage of the Sugar. It also improves the accuracy, reduces the distortion, and offers high retest reliability. By integrating these modules, we've been able to develop a comprehensive deep learning-based pre-processing pipeline, which we've named DeepPrep. DeepPrep not only integrate our own deep learning modules like FastCSR and Sugar, but also integrate the state-of-the-art algorithms from other research groups, including the FastSurfer and the SenseMorph. This pipeline allows us to pre-process both structural and functional neuroimage data like FRM-Prep. But DeepPrep enhances the speed and scalability and robustness. So let's see the performance of the DeepPrep. We first evaluated the DeepPrep on several benchmarks like TSNR, the registration, task activation, city-based RSFC, and also the functional connectome, reliability in functional connectome. Across all metrics, DeepPrep produced produce the outcomes that are very similar or even better than FRM-PrEP. But more importantly, DeepPrep achieves tenfold acceleration over FRM-PrEP. DeepPrep completed a scan processing around 30 minutes. Let me show you an example. As you know, UK Biobank has 15,000 subjects with neuroimage data. We wanted to pre-process all of this data using a high-performance cluster at our institute. If we use FRM-PrEP, it will take us 3 months. But if we use DeepPrep and start the pipeline today, we can see our results by next Tuesday. And then note 3 months later, when we've already forgotten what we were trying to do. Beyond speeding up, we also wanted to know how well does the DeepPrep handle real clinical data. So we tested on a set of over 50 challenge clinical cases, including stroke patients, tumor patients, and trauma patients. These are exactly the kinds of cases that often break traditional pipelines. The results were very encouraging. DeepPrep successfully completed the pipeline for 100% of these cases, and about 60% of them produced outputs with acceptable quality. In contrast, FRM-PrEP struggled quite a bit. Here are a few examples. In many cases, FRM-PrEP failed scalp stripping or can't even reconstruct cortical surface at all, and also maybe produce the misaligned registration surface or volume. But DeepPrep handles them correctly and consistently. And in our lab, we conducted a lot of clinical trials for post-stroke functional rehabilitation. So we encountered a lot of patients that can be pre-processed by FreeSurfer or FRM-PrEP. But we use DeepPrep successfully pre-processed over 200 patients that can be processed by these traditional pipelines so far. Moreover, DeepPrep is easily to deploy and easy to use. We use Docker and Singularity to package our pipeline, so you can easily use it in different operation systems, including Windows, Linux, and Mac OS. But unfortunately, Mac OS with M series chips can't completely finish the whole pipeline. But Mac OS with Intel CPUs works well. DeepPrep can be operated in CPU-only device, and the pre-process time is around 1 to 2 hours, depending on the CPU. It's also much faster than FRM-PrEP. If you have a device with GPU, it could be much faster. And recently, we found it could be even faster, even to 15 minutes using the latest Intel CPU and NVIDIA's RTX GPU. But it's worth noting that only NVIDIA's GPU can be used to accelerate the pipeline because we need CUDA. Furthermore, we also develop a GUI for users who are not familiar with command lines. So you can click and select to run the pre-processing using DeepPrep. And we designed an interesting interface we call Quick QC. Although right now it only supports head motion estimation before pre-processing, but it's very useful for quick screening high head motion cases. So in the future, we will provide more features for this interface, and you can see more details in this link or just Google DeepPrep. After we establish the computationally efficient and clinically robust pre-processing pipeline, we can explore personalized functional mapping and validation. Our lab's 2013 Neuron paper unveiled the comprehensive brain map of individual variability in functional connectivity. This revealed a contrast Substantial variability exists within the association cortex, while primary motor cortex and visual cortex shows relatively low variability. What's more, our recent studies extend these findings to neonates and macaques. Their individual variability maps look pretty similar with adult humans. That indicates individual variability in brain functions is a very principal functional organization of the brain. The individual variability map inspired us to develop the iterative personalized functional parcellation approach in 2015. This method parcellated the subcortex into 18 functional networks for each individual. The parcellation is based on 30-minute fMRI data show a high test-retest reliability of over 80% Dicey coefficient. The individual differences in personalized network topography also underscore the significant variability among the individuals. Then we achieved a fine-grained parcellation through applied a divide and conquer strategy. We identified up to 213 functional regions within several cortex. The personalized functional parcellation maintain a high test-retest reliability over like 80% in Dice coefficient. The fine-grained parcellation further enhances our understanding of the detailed functional architecture at the individual level. Beyond the reliability, validity is another critical aspect of functional mapping for like causal inference and clinical applications. So let's take the motor regions as an example at first. We can use task-evoked activation to validate the resting state-based functional parcellation. For example, we divided the motor strip into 7 distinct regions from dorsal to ventral. Notably, 2 regions correspond precisely to activations from hand and thumb movement. It's interesting that inactivated regions, shown here, will align with the newly discovered functional networks, somatic cognitive action network, or SCAN, like by Nico Dawsonbeck and Evan Gordon. Moreover, beyond the non-invasive validation, we pursued invasive validation for our parcellation. In collaboration with neurosurgeons, we used the electric cortical stimulation during the neurosurgery to confirm our parcellation accuracy. To date, we've validated our method in over 50 cases, achieving nearly 100% sensitivity. Our journey of functional brain mapping doesn't stop at the primary motor cortex. Next, we move to the association networks. They are more complicated because they show higher degree of inter-individual variability. I'm interested in language network mapping and validation, but it's highly challenging because language network not only varies in localization, but also in lateralization across participants. In our neuron paper, that the degree of variability is the highest in the frontal parietal network across YOS network, 7 networks atlas, in which language network is absent. But when we turn to Gordon's 17 network parcellation, it's interesting, but not surprising that language network shows the highest degree of individual variability in functional connectivity. So we use the precision functional mapping to map personalized language networks in 12 subjects from our lab. Each of them underwent 300-minute or 5-hour resting state fMRI scanning. We found each of them show different language network topography and different degrees of laterality. 11 subjects displayed a left lateralized language network, while only 1 showed a right lateralized network. We validated the accuracy of our population through 1-hour language localizer task scans. Both the topography and lateralization of the networks closely align with the task-evoked activations. It's interesting to note a high correlation between the lateralization index of our population and that derived from task activations. We further expand our scope to subcortical areas using a winner-take-all method. We identified language-related regions in the caudate and contralateral cerebellum for each participant. These regions are also matched with activations from language localizer tasks, providing the validation of the subcortical language area. Again, the validation is a cornerstone of our personalized functional mapping for clinical applications. So we performed a validation experiment based on the unique chance provided by the epilepsy neurosurgeries. In collaboration with two medical centers, we collected 46 epileptic patients waiting for neurosurgery. Before the surgery, we mapped each patient's personalized language network based on their 30-minute resting state fMRI scans. During the surgery, neurosurgeons performed the surgeries according to their own clinical experience and were blended to our mapping. After the surgery, we compared the clinical outcomes with whether patients' personalized language networks were resected. We found whenever personalized language regions were resected or compromised, patients experienced language deficits after surgery. In contrast, if language regions were not resected, like this patient wouldn't show post-surgical language impairments. The surgical validation provided a strongly causal evidence for the accuracy of personalized language mapping. After confirming the high reliability and validity of our personalized functional mapping, we have more confidence in its applications for guiding neuromodulation. Here, we used to guide cortical functional functional mapping TMS targeting. I think TMS is a good partner with our fMRI mapping because of its non-invasive nature and comparable spatial resolution with functional networks. Here, I'd like to share a randomized clinical trial on post-stroke aphasia at first. Previous efforts focused on the IFG or Broca's area to treat the post-stroke aphasia. But when I tried TMS to stimulate my FG by myself, it's surprisingly painful. I suppose this might be because TMS may stimulate trigeminal nerve branches. Another concern about the target is stroke lesions often surround the IFG, so directly stimulating the perilesional areas is risky. So we chose a different target, the SFG, or superior frontal gyrus. This is a more dorsal language areas, but it's actually directly connected to the IFG through the frontal isolate tract. Because of the significant individual differences in language networks, as I shown before, we use the personalized functional imaging over group atlas to identify the personalized targets. This allowed us to pinpoint the exact RTMS targets for each patient, as shown by these green dots. We administered 3-week stimulation. The language performance in the active stimulation group improved a lot with 20-point increase in WABAQ. It's a facial quotient. But the sham stimulation group just improved 5 points. Moreover, the response rate is 100% in the active group, but less than 30% in the sham group. Here, let me show you an example. It's a patient video before and after the treatment. This patient is a chronic aphasia patient who had struggled for nearly 1 year. Because these videos use Chinese to talk, so I added an English subtitle. Initially, she couldn't communicate beyond 2 syllables, like 西花 or 小花, without any meaning. You can see. Moreover, we also applied a very similar approach to the hand motor network in patients with post-stroke motor deficit. Once again, the effect size was substantial, and the response rate in active stimulation group was around 60%, while the sham group showed almost no improvement at all. We also extended this approach to address post-stroke cognitive impairment. In this case, we identified a personalized frontal-parietal cognitive network for each patient and applied stimulation at different doses. A high-dose group we used 3,600 pulses per day, a standard dose of 1,200 pulses per day, and a sham condition. Here we observed a very clear dose-dependent effect. The high-dose group showed a significantly greater improvement than the other 2 groups, with a response rate over 90%. Given the strong clinical potential of the personalized functional image-guided neuromodulation, we are now building an open source platform that will allow automatic targeting planning for each patient. This platform combines DeepPrep with our individualized functional participation approach, so it will be fast and robust. We expect to release it early next year, and we hope it can help support more clinicians and patients and researchers in the future. Okay, next, I'd like to share our recent study on the scan in Parkinson's disease. This research combines our personalized functional mapping and neuromodulation techniques. I'd like to start with a quick video. This is a PD patient with freezing of gait. As you can see, he walks forward just fine, but when he tries to turn around, things break down. His body failed to excuse the order from his mind. It's like his intention is there, but the execution fails. Okay. There's another interesting example, paradoxical kinesia. Normally, PD patients move very slowly, but in emergencies, they can burst very quick movements, like during a big earthquake in Italy. 14 PD patients ran out of their houses. In this article, they described these patients just jumped out of bed and ran out of the building and yelling to relatives to follow. So it's very interesting, because PD is not a simple movement disorder. It's not like their legs or arms. These effectors can move. The real problem seems to be a disconnection between their actions. When it comes to the PD circuit, people typically refer to the loss of dopamine neurons in the SNPC and its impact on striatum, GPI, STN, and thalamus. These subcortical regions are well defined in the PD circuit. However, when we talk about the cortical involvement in the PD circuit, most models regarded it as the primary motor cortex as a whole, because they are all impacted by the continuous map in the Pamphil's homunculus model. However, the scan paper published in Nature 2023 offers a new insight in functional organization of the motor cortex. The model shows that the effector-specific regions like foot, hand, and mouth are not continuous, but separated by three inter-effector regions shown in purple. These three inter-effector regions are highly connected and organized into the somatocognitive action network, or SCAN. And the SCAN plays a very critical role in action planning, movement coordination, and autonomic functions. These functions well correspond to the diverse motor symptoms in PD. So in this work, to explore the roles of the scan in PD, we applied the DeepPrep to multiple large-scale PD neuroimage cohorts and neuromodulation trials. First, our primary analysis focused on the cortical functional connectivity of each subcortical regions within the PD circuit. These functional connectivity patterns are surprisingly consistent. These regions all predominantly connect with the scan rather than effector-specific regions, right? This suggests that we've been calling the PD circuits as a movement circuit might be more accurately described as a scan circuit. Moreover, we observed the cortical-subcortical hyperconnectivity within the scan in PD patients compared to healthy controls. These findings were drawn from a large-scale PD precision image dataset, and importantly, we replicated this result in an independent dataset. So the scan hyperconnectivity might be a pathophysiological marker of PD. When it comes to PD treatment, the most successful neuromodulation technique for PD is DBS, deep brain stimulation. We have three commonly used targets like STN, GPI, and VIM. We summarize the sweet spots of these targets from a multi.
Dr. Ren, I think we have lost you again.
Okay.
Yeah.
Can you hear me right now?
Yeah. Thank you.
Very unstable. Okay. You can see my screen, right?
Yes.
Okay.
Yeah.
Okay, let's start by this. We summarize the sweet spots of these targets from a multi-center study, including over 300 patients, and estimated their cortical functional connectivity. We discovered that their cortical functional connectivity aligns with the scan again. This may indicate that these DBS targets actually all stimulate the scan circuit to reduce the symptoms. Beyond the neuroimage evidence, we'd like to validate our results using neurophysiological data. We used the STN-DBS ECOG dataset with 17 PD patients and 300 ECOG electrodes in M1. This dataset was collected during the DBS surgery. Neurosurgeons gave single pulse stimulation to the STN and recorded the cortical evoked potential using ECOG. So we showed the top most responsive ECOG electrodes in M1, predominantly located within the scan rather than effector regions. Moreover, scan's cortical evoked potential are significantly stronger than effector at most time points. So this is a strong evidence to support our neuroimage findings from the neurophysiological aspect. After we identify effective DBS actually stimulated the scan circuit, we'd like to know if STN DBS reshapes the functional connectivity in the scan circuit, and how it reshapes the scan, reshapes the scan circuit. So we collaborated with Tsinghua University and they designed a 3T MRI compatible DBS system. It allows us to perform precision functional mapping in patients with DBS. We spend a lot of time and money to collect the precision image data, DBS dataset, including one preoperative time point and 4 follow-up time points within 1 year for each of 14 patients. And we plan to open this dataset this year. We can see these 14 PD patients, their motor symptoms highly improved after DBS. Then we checked out the cortical functional connectivity of the scan. Consistent with the previous results, PD patients show scan hyperconnectivity before DBS. But 1 month after DBS implementation, the scan connectivity remarkably decreased. Then 3 and 6 and then 12 month follow-up time points all show lower functional connectivity strength than the pre-op. The below figure shows the corresponding statistics. The post-operative changes in functional connectivity reflects the normalization effect of the DBS to the scan hyperconnectivity. Although DBS works really well for Parkinson's disease, it is invasive and expensive. In China, less than 1% of PD patients actually get the effective therapy. That's why non-invasive neuromodulations like TMS are really attractive. They could reach a lot of more people. But past TMS studies haven't shown great results. One issue we guess is that most of them just say they target M1 or primary motor cortex, which is really vague. We think the real problem is that they actually stimulated the effector regions, not the scan. So we conducted a prospective clinical trial to directly compare rTMS targeting scan versus effectors. Patients were randomly assigned to 2 groups, each receiving 2 weeks of stimulation. The result is very exciting. The scan group improved twice as much as the effector group in motor symptoms. Then we look at the functional connectivity before treatment. Before the PD treatment, again, we can see very strong scan hyperconnectivity. But after treatment, the scan group showed a clear reduction, just like what we see with DBS. This suggests that even though DBS and TMS are very different, they might work through a very similar mechanism of action, normalizing scan hyperconnectivity. In addition, we explored the potential of scan-guided focused ultrasound treatment in tremor-dominant PD. In the dataset, 10 PD patients underwent MR-guided fuse targeting the VIM. We used their individual preoperative functional connectivity to identify the optimal target for each patient. We found that the distance between the optimal and actual target was significantly anti-correlated with motor symptom improvement. But there is no correlation when we use effector-specific region to identify the optimal targets. This finding suggests a VM targeting may be optimized in individuals by considering the scan functional connectivity. Okay, in summary, in this work, we showed that PD circuit
Dr. Ren, I think we lost you again. Yeah.
Sorry.
Maybe
Can
you
you
can
hear
share.
me?
Yes, right now it's okay. Yeah.
Sorry. Okay. In summary, our work shows that PD circuit is actually the scan circuit, and different neuromodulation techniques actually target the scan nodes, target the scan circuit by the different nodes. The scan hyperconnectivity is a core pathophysiological marker of PD, and it could be normalized by both invasive and non-invasive neuromodulation. This is a truly team effort, and I'd like to particularly acknowledge Professor Hoshen Liu. Thanks for his great support and supervisions. And I'd like to thank Zhang Wei. She is our PhD student, and she's a colleague of the PD project, and also the Anning. He is our talented engineer, who is also the co-lead of the DeepPrep. And also, I'd like to acknowledge our collaborators from China and the US. Thanks for their suggestions and data to support our this works. And thank you for your attention. And I'm happy to take questions. And by the way, you can follow me on Twitter or X through scanning the QR code or search my name by or my ID. Okay.
Thank you very much, Dr. Ren, for the fantastic talk.